the Micro Lab for giving this opportunity to get connected by a pan-India panel discussion, and during the tough times of the COVID-19, still not leaving us. And I request all my colleagues, all the delegates, everyone, to stay safe in spite of COVID giving a little relaxation. Kindly follow all the safety precautions. Already, today we are going to have an interesting panel discussion with the 3 panelists already been introduced. We have an endocrinologist, madam, and we have cardiologist, as well as we have a nephrologist. And we have the endocrinologist from Guwahati, as well as Dr. Chandra Kumar Das, cardiology from Guwahati, and we have Dr. Ratan Jha, nephrology from Hyderabad. So I am in Coimbatore. Almost we try to connect at each end of the country, and so we will start with the panel discussion. Already Manjula madam has given an overview of how the SGLT2 has been positioned and what are the pleiotropic benefits of the SGLT2 in the cardio-renal continuum of the risk in diabetic people. And so we'll start the panel discussion, and I request all my colleagues to be more specific and to be brief, so that we can finish the program also in time. And so first question is, how often do you use SGLT2 inhibitors in your practice? And what are the compelling reasons for your choice? So we'll start with the endocrinologist, madam.
Thank you so much, sir, for that question. So we know, like, there has been a vast change, or there has been a vast change in the landscape of treatment of diabetes, and of late with the invention of, or with the discovery of SGLT2 inhibitors or use of SGLT2 inhibitors, the cardiovascular data, which CVOT trial, which came in 2015, the areas have broadened even further. So gradually, as we go into the data of SGLT2 inhibitors, they have now been recommended based upon their cardiovascular and renal profiles to be used even as a monotherapy for initial use in patients having type 2 diabetes with, say, the compelling reasons like having incipient nephropathy, having established atherosclerotic cardiovascular disease, or having symptoms of heart failure. So all these are actually compelling indications for initiation of SGLT2 inhibitors, besides the glucocentric rewards which we received by using SGLT2 inhibitors in bringing down the hyperglycemia. These are the added pleiotropic benefits which we incur with the use of SGLT2 inhibitors in our patients.
I think we'll move on to Dr. Chandra Kumar Das, cardiologist. Your take on this? Kindly unmute, please. Unmute. Dr. Chandra Kumar, please unmute and talk.
Yeah. Okay. Thank you for the question, sir. This is very much a relevant question. Like you see, in this mainly for the heart failure patients, we have some established therapies that is already established like around 15 years ago, and now we have another molecule, this ARNI, and lately this SGLT2 inhibitors has emerged as the having the cardiovascular benefit. Mainly is like dapagliflozin. If you see in this heart failures, you have this has a great benefit. The number needed to treat is like around, it is come to 21. Some studies like it for heart failure repeat hospitalization is coming to 28 NNTs. So it has a great benefit for the heart failure patients. So for that we are like in my practice, I'm frequently using this SGLT2 inhibitors for dapagliflozin for heart failure patients, and if the patients are already in diabetes, and then this empagliflozin also for the diabetic patients with established CAD and AVSD risk.
Thank you, Dr. Chandra Kumar, and we will move to Dr. Ratan Jha, nephrologist, for your take on this question, please.
The clinical situation where a nephrologist prescribed the drug SGLT2 inhibitor has now become quite wide. We prescribe it for diabetic kidney disease as well as a non-diabetic kidney disease based on the recent reports that is there. it has been found that there should be some reason not to prescribe this drug in a context of chronic kidney disease. Like we talk about, there should be some reason not to prescribe ACE or ERB in a patient of kidney disease with proteinuria. Similarly, we should have some justification not to prescribe this drug because it is not only renoprotective, cardioprotective, as well as reduces the mortality in various studies and seen that the patient has lesser mortality. And in the recent report, it has been said that this drug reduces the risk of even developing diabetes in a CKD population. So these are the reasons why we have no justification not to use it in a CKD of any situation unless the GFR is below 30.
All the panelists started well, and we have started with a baseline question, general question. Probably as we move on, we will be having more specific question answered. Tailored to the particular specialty. Probably the next question will be which SGLT2 inhibitor would you prefer in obese patients with diabetes? Probably obesity is area of our endocrinologist. So Dr. Nilakshi Deka, your take on this question, please.
Sir, I can't really choose one SGLT2 inhibitor over the other when it comes to addressing obesity or weight reduction in individuals having type 2 diabetes, because the data, like there are certain things which are similar or which are a kind of class effect for SGLT2 inhibitors. Say the effect on the kidney profile, that is improvement or retardation in diabetic kidney disease. Secondly, influence in decreasing the hospitalization for heart failure. They are uniform across all classes of SGLT2 inhibitors. What the difference is actually related to cardiovascular death, which empagliflozin has shown to decrease, whereas the other SGLT2 inhibitors, which have a large cardiovascular outcome trial, they do not have an effect. But that is again explained by a difference in the patient baseline population, because in empiric outcome, 100% of the individuals or 100% of the patients had actually existing cardiovascular disease, whereas it was 60% of the patients in the declared TIMI trial did not have any existing cardiovascular disease. So when we speak about dapagliflozin vis-a-vis empagliflozin or canagliflozin, I think the reduction in weight loss is uniform across all these three classes of SGLT2 inhibitors, and the weight loss that these contribute in their respective trials have been to the extent of 3 to 4 kgs with each. So I think weight reduction would not really influence my choice of choosing a particular SGLT2 inhibitor over the other.
If you ask me that question, probably as a moderator, I would like to give my opinion on this one. And basically, in my personal experience and from some data, I find the canagliflozin works well for a weight reduction compared to the other SGLT. By and large, even though it's a class effect, everyone, most of the trials have almost equal in the weight loss and the benefits. Each one differs, but by and large, I find the canagliflozin works in a better way in terms of weight reduction. So we will move on to the next question. Do you think the SGLT2 can be used in diabetic with atherosclerotic cardiovascular disease? If yes, how often do you encounter such patients? And what is the kind of weight loss seen in patients, say, after 3 to 6 months? Probably, this question we can start with Dr. Chandrakumar Das. So, diabetes and atherosclerotic cardiovascular disease.
Yes, sir. This is a good question and relevant. If you see if there's diabetes and there is atherosclerotic risk, then definitely you have the choices of SGLT2 inhibitors, as the madam has said, that even though the benefits, this like in the empiric trial has shown that this primary endpoint of cardiovascular death or non-fatal MI or non-fatal stroke, there's significantly decreased with empagliflozin, and in declared TIMI this was not found, or as there was some baseline difference. So ultimately, I think all these SGLT2 inhibitors have the benefit and cardiovascular outcome, and definitely all have the benefit in heart failure hospitalization or heart failure death for heart failure or repeat hospitalization. So I think
the weight loss part. Well, can you answer the weight loss part? What kind of weight loss seen in the patients of 3 to 6 months of therapy?
Weight loss, all they have shown the weight loss. I don't think there is difference like in with any one of them. All have the mechanism itself goes in the favor of weight loss. So in my practice, I used to use the dapagliflozin, and this is because there's reasons like in my patients the expenses also matters. So with dapagliflozin also I have seen the weight loss is there, and in the 3 to 6 months. So
What is the weight loss you encountered in most of your patients?
these are in my patients, like if they're having a heart failure and all, so only dapagliflozin, only this molecule is not
We are
responsible.
not only concentrating on heart failure, Dr. Chandrakumar. We are not gone into the truly into the heart failure as such now. Overall,
Yeah.
in a
Yes, sir.
diabetic patient with because ASCVD, we talk atherosclerotic cardiovascular disease. Okay, so in that, as a cardiologist, you all will agree. Whenever there is an overweight or obesity, it increases the cardiovascular risk
Yes.
in the diabetes. Okay, so any weight loss in a diabetic patient, obese person will be definitely have a beneficial effect in the clinical outcome. Any weight reduction can lead to a reduction in the blood pressure again, and the insulin resistance comes down. And by and large, it's going to be one, and the glycemic benefit. Second, probably it might also be transferred into the cardiovascular clinical outcome. So that probably the weight gain. Probably, do you want to add, Dr.
I
Nilakshi? Can I move to Dr. Nilakshi to add on to this? The weight loss?
No, sir. No, sir. I think
The weight loss in 3 to 6 months. What is your experience in
3 to 4
patients?
kgs. So it's different from different in different individuals. So actually, the weight loss process, it depends on the baseline weight. So if an individual has a higher weight or a higher BMI, that the chances or probability that the weight loss will be more is higher in such an individual. But an individual who starts with a lower BMI, the weight loss would be lesser compared to another individual having a higher BMI at baseline. So on an average, it is 3 to 4 kg. Sometimes it is 2 to 3 kg. And sometimes we see many patients where they lose weight to the extent that we actually have to withdraw the molecules because the patient becomes so concerned. So I think that the response is different for different patients, but on an average, it is 3 to 4 kgs, and it depends upon the baseline weight when the patient is initiated on this molecule. Higher
I
the
agree.
baseline weight,
I agree.
higher is the weight loss.
Agree, Dr. Nilakshi. Probably my experience is we get around 5 to 7 kgs of weight over a period of 6 months time. I've seen patients. As you said, the higher the baseline BMI, there's going to be a weight loss, and the weight loss is also not only the there's a loss related to the visceral fat, also visceral, not only the lean body mass as well as the visceral fat is also reduced. Probably this data suggest, to inferring as that by doing most of the SGLT studies, when they've done with the DEXA scan and found out there is a reduction in the visceral fat mass also, not only the simple diuresis in terms of leading to weight loss, because once the diuresis, probably there might be a regulations in the receptors, so the diuresis cannot continue for a longer time. Probably the visceral weight loss, and average, as you said, 3 to 5 kgs we get, and some patients we get higher weight loss. So we will move to the proper nephrology question to Dr. Ratan Jha. So what is the role of SGLT2 inhibitors in nephrology practice? Over to you, sir.
The role of SGLT2 inhibitor in nephrological practice has come into focus. They started with diabetes, and now we're talking about non-diabetic chronic kidney disease. Whenever you're prescribing any drug in the context of chronic kidney disease, we look at 3 endpoints. The renal endpoints, whether the GFR slope is stabilized, proteinuria is coming down or not, mortality, renal as well as non-renal mortality are reduced or not, and any other kind of pleiotropic benefit is seen or not. So in this context, SGLT2 inhibitor is now next to the RAS blockade as an important therapy that has to be prescribed in most of the patients that we see as a nephrologist, unless there are contraindications not to use it, that the patient has a recurrent UTI or patient has very low GFR or some other reason for which the patient cannot take this drug. So this is a drug which is prescribed for renal protection in a patient of renal disease, for cardio protection, because one of the commonest causes of death in a cardiac patient is a cardiac death, or renal patient is cardiac death, and then to prevent the risk of progression of disease to end-stage renal failure, And now it is said that in the one of the recent meetings of ADA, it was highlighted that if this drug is used in a non-diabetic situation and CKD, it reduces the relative risk of diabetic occurrence is almost 38%. So it can be prescribed also to reduce the risk of diabetes, because patients who are having a uremic milieu are having a higher risk of impaired glucose tolerance. So there are various reasons for it to be used and included in the prescription, and there should be no reason to not use it unless there are contraindications.
Thank you, Dr. Atanja. And probably, even though the SGLT2 inhibitors basically started as a anti-hyperglycemic drug, anti-diabetic drug, now following the data, and because the cardiovascular outcome trials have given a lot of insights, and then moved on to the nephrology trials, various CVOTs have taken that, told us, and now the SGLT2 inhibitors are not only diabetologist perspective or endocrinologist perspective. Now they are most cardiologists and nephrologists also. They feel the SGLT2 class belong to them. So from the glucose-centric approach, as Dr. Nilakshi said, we have moved away from glucose, and we are looking into the cardio-metabolic, cardio-renal, and metabolic and renal risk reduction. So thank you, Dr. John. We'll move on to next question to the cardiologist, Dr. Chandrakumar Das. And okay, do you use SGLT2 inhibitors in the post-operative cardiovascular disease patients?
Yes, sir.
Post-operative.
Yes, sir. Yes, sir. Usually after suppose post-operative, post-PTCA patients, if the left ventricular ejection fraction is in the lower side, then also there is indication. And if it is not in the lower side also, then also in diabetic patient to use usually the empagliflozin I use in my practice. Empagliflozin has shown the cardiovascular benefits, this death for cardiovascular cause. So in those patients I use empagliflozin in diabetic patients. And in those patients, if there is heart failure with reduced ejection fraction, the left ventricular ejection fraction is less than 40%, then I used to go to dapagliflozin as well.
Okay. Thank you, Dr. Chandrakumar. We will have a question to Dr. Nilakshi. Can you use dapagliflozin in newly diagnosed diabetic patients?
Yes, sir, of course.
Yeah.
Of course, we can use. And in fact, since these have a mechanism of action which circumvents or overrides the beta cell function, these are actually a class of molecules which can now be considered to be disease modifying, where we are not pressurizing the beta cells to secrete more and more of insulin, unlike the sulfonylureas or secretagogues do. What we do is we have a molecule which leads to glucosuria, thereby decreases the blood glucose levels in a very short span of time, leading to reduction in glucotoxicity, which is caused by severe hyperglycemia. This in turn again leads to improvement in insulin sensitivity. And in fact, these molecules, they help to improve the quality of insulin, which is secreted from the beta cells when they are under pressurized situations like glucose toxicity caused by hyperglycemia. So they can definitely be used in patients who are diagnosed for the first time, and they are good to be. In fact, these are the class of molecules. So in using it for the first time, that can be done with any class of molecules. But the beauty of this molecule is that it can even be used and it would prove to be efficacious, even if an individual has diabetes of say 15 years duration. So when an individual has diabetes of a longer duration, the apprehension remains that whether a molecule added to such a patient where the beta cell function is already dwindling, would a molecule tend to have an efficacy or no? So the beauty of SGLT2 inhibitors or dapagliflozin, if we speak, is that they are effective in reducing hyperglycemia, in meting out the benefits regarding the cardiovascular and renal profile across all stages of diabetes, be it early, newly diagnosed diabetes, or be it diabetes of several years duration, leading to coexistent comorbidities like cardiovascular diseases and renal diseases. So this is a class of molecule which has efficacy in all stages.
Yeah, probably we are convinced Dr. Nilakshi that it can be used in any stage of diabetes, but want to know from you mainly the whether they can be used in the newly diagnosed diabetic patients. And you also said yes to the question, but most of the guidelines till date, the guidelines do not recommend SGLT2 as the first line of drugs in the management of type 2 diabetes, unless there are compelling indication like ASCVD or heart failure, or ACVD and heart failure and CKD. Such an indication only. Most of the guidelines, I know you'll be agreeing with me. Both all my colleagues in nephrology and already my friends Dr. Chandra Kumar Das and Ratnanja also will agree. And newly diagnosed diabetic patients without the involvement of an ASCVD or a heart failure or a CKD, SGLT2 are not approved to be used at present. And if they have other complications, for example, you can quote the European Society of Cardiologists put the SGLT2 on the first line, even before the Metformin, whether they used Metformin or not. But most of the all guidelines say that the SGLT2 will be next drugs to the Metformin in just the plain diabetic patients. And so we'll move to the next one. And I think again, coming to a cardiology perspective, and when do you like to use an SGLT2 in post-operative cardiac patient with diabetes? Immediately or after some period of time? Dr. Chandra Kumar Das?
Yes, sir. The practical question. See, if the patient is having, suppose after operation means the angioplasty, if the patient is having myocardial infarction, and then found out in by angiography there is some blockage, and we had to do the angioplasty. So after angioplasty, if the patient is in failure, if needing the diuretics, then in those patients we wait a bit for the failure part has to resolve. Then only I used to use this SGLT2 inhibitors or ARNI or whatever. So if the patient is not in the failure, then directly I can use the SGLT2 inhibitors. So when the one way I use the diuretics, then I better to this off the diuretic then and to use the SGLT2 inhibitors. Otherwise, what happens? The diuresis becomes more in comparison to the means like single if you give the IV diuretics.
I think that Chandra Kumar, the ARNI and SGLT2 are not almost comparable, and in all aspects.
ARNI is
So
not for every patient.
Yeah. So the patient with a reduced ejection fraction or a the patient with a heart failure.
Yes, not in heart failure, reduced ejection fraction. Yeah, okay. See, if the patient has come with a myocardial infarction in window period, mostly in those patients the heart failure does happen. In those cases, this SGLT2 inhibitors we can directly use. The patient is diabetes. The benefit is more. It is said that if there is benefit, why should be late? Why should you give the molecule later? You should give the molecule as early as possible when there is benefit.
Okay, Chandra Kumar, thank you. And we'll move on to the question to our Dr. Nilakshi Deka. Would you prefer to use the SGLT2 in post-operative, for example, the cataract and tooth extraction in patients with diabetes?
Yes, sir. It can be used in operations like cataract or tooth extraction, but rather we should be a little more cautious in using patients who have had a major surgery. 2 days prior to surgery, this has to be stopped, and also maybe a week after surgery when the patient is recuperating from a major surgery or a major septic episode. In such a case, this molecule will be contraindicated. Otherwise, there's no problem in using, there's no contraindication in using this molecule for tooth extraction or post-cataract surgery patients.
Generally, I tend to use most of the time the insulins during the cataract and tooth extraction most of the time, and the pre-operative period, and at least for some time in the post-operative period, we try to keep them up with insulin till we are convinced that the surgery, the healing has been done, and overall the patient has recovered well. This is my take on that, Dr. Nilakshi. You are muted. You're muted. Nilakshi, you wanted to say something? It's muted. Hello?
Hello.
Yeah.
Nilakshi, you're muted. You unmute, please.
I'm sorry, sir. I got a bit technically disconnected. So could you please come back with the question once again?
Question we have done and just supplemented your answer to the question, saying that I would be, personally, I use the pre-operatively and at least for a period in the post-operative period, even though it's a cataract or a dental extraction, till I am convinced that healing is pakka. Okay, till the time I use insulin, then switch over to the other oral agent. I just supplemented your answers.
Yeah, in fact, when a patient is going for cataract or tooth extraction, we would rather ask the patient to not take a sulfonylurea or not take the something which is more powerful, because they have more propensity to cause hypoglycemia. The only fear is that of hypoglycemia with an oral hypoglycemic agent taken on a day of surgery, which dapagliflozin has very less potential to cause hypoglycemia. So that way also it can be seen as a safe molecule to be used in such simple surgical procedures as this.
Probably the post-operative, the cataract, when you talk about cataract, usually elderly patients, they undergo cataract most of the time, elderly people, there will be loss of thirst mechanisms and the support mechanism is less, and they are prone to develop dehydration. So in these patients, we just try to keep the oral drugs for a short period of time till they recover well and they can continue the routine drugs. So next question is nephrologist Dr. Ratan Jha, and a diabetic patient had 1 or 2 incidents of UTI in the past, and now he has diabetic kidney disease. Would you prefer to use SGLT2? Dr. Jha?
Yes.
Ratan Jha, yeah.
Yes, my answer is that past history of UTI should not be a reason of reluctance to use it, because if the glycemic control is good, it is said that people of diabetes will have the same kind of UTI compared to non-diabetics, provided they are not having any obstructive uropathy. So we will use this drug if the person has no obstructive uropathy and currently not having uncontrolled diabetes. Then this drug is to be used to protect the kidney, protect the heart, and protect the life of the patient. So hence you will use it.
So probably I just want to add to Dr. Jha's answer that they're given as a UTI, urinary tract infection. It depends upon whether the lower UTI or upper UTI. Okay, so if it's some sort of genital myocardic infection with a lower UTI, it's fine. And if it's going to be an upper UTI like a pyelonephritis, I am really skeptical in using this. When a history of 1 or 2 incidents of acute pyelonephritis with some complication, I generally tend to reserve the usage of SGLT2 inhibitors in these patients. If it's a lower UTI, it's fine. Any of the other panelists want to give their call on that? Dr. Nilakshi?
For UTI, even if it is lower urinary tract infection, a bacterial infection, I would still discontinue the SGLT2 inhibitors for a brief period until the patient is recovered of the symptoms like dysuria and the pain and cramps which the patient faces. But if it is a trivial genital tract infection caused by mycotic organisms, then of course it can be continued while we are adding anti-mycotic agents to address the situation. However, in some patients, this becomes a really nagging problem and it becomes persistent and chronic. In such a case, unfortunately, when a patient has chronic UTI, in certain cases, we do need to discontinue this molecule for good, despite knowing the benefits that this molecule, despite the benefits that we know we can achieve with the use of these molecules as regards the cardiovascular or the renal profile. So in all circumstances, we actually try to aid the patient or help the patient circumvent or go through the existing UTI or GTI so that he can be benefited again at the end of the infection by reintroduction of such a molecule to help him in the bigger perspective or in the longer run with major complications, by reducing major complications than this trivial UTI or GTI.
Sometimes what I just wanted to highlight here is the upper urinary tract infection. Basically, the pyelonephritis. Many a time we come across patients with an acute pyelonephritis with papillary necrosis, with debris forming and getting into complications. The 1 or 2 episodes, definitely, they are not the candidates for the SGLT2 inhibitors.
Yeah.
Number two, even though, sometimes with the diabetic patient with autonomic neuropathy, most of the people with when they have autonomic neuropathy, they have a stasis in the urine, the bladder, they will not be able to empty it fully. Most of them, they have a chronic UTI, and they have cystitis and ascending infection also. Such people we are not able to eliminate the bacteria from them. And these group of patients, we need to be very careful in using the SGLT2 infection inhibitors. And Dr. Ratanja, coming to you again, what are the essential indications for SGLT2? Can you be specific to this question? Essential indications for SGLT2 inhibitors in your view as a nephrologist.
The essential indications for using SGLT2 inhibitors are diabetic kidney disease with proteinuria, usually with associated cardiovascular dysfunction, and chronic kidney disease patient with a proteinuria based on the DAPA-CKD trial that is there. The only area where this drug has not been studied is the polycystic kidney disease, as well as an autoimmune or vascular disorder, where we cannot prescribe it based on the information that is available. So all patients of chronic kidney disease where the GFR is above 30, it can be used, provided there are no risk factor like the UTI that you talked about, which is a nagging UTI. What we find in our clinical practice is that people equate pyuria with UTI, and thereby they do not give this drug to large majority of patients who may benefit with it. So if it's a true UTI, a past history of serious UTIs are happening, drug may not be tried, or one may try to look at it, whether you can reintroduce it and see whether the patient has any kinds of problem or not. But barring that, probably all patients who have no history of UTI and no history of obstructive uropathy or diabetic cystopathy that you talked about, all diabetic and non-diabetic patients with a GFR of 30 should get the benefit of using the SGLT2 molecule of any type which are available, which are found to be cardio or renoprotective.
Why you have selected the eGFR of 30, Dr. Ratanja?
Because
can you elaborate on it?
Most of the trials which have been done have done with the idea that probably in the late stage of kidney disease, the benefits may not be seen, and hence that was the cutoff. The 30 ml GFR cutoff was there. But now the recent trials are now lowering the GFR cutoff to 20 ml and trying to see whether the benefit is there or not. One has to understand conceptually that whenever a kidney dysfunction happens, whatever remaining nephrons are there are suffering from hyperfiltration injury. So even if the nephron number is less, it is suffering from hyperfiltration, where this drug SGLT2 will benefit the patient mechanically, because it reduces the intraglomerular pressure. So we believe that even if it is GFR is below 30 ml, the benefits will be seen of CKD progression getting halted. And this has been found even in Credence trial, where the drug was started when the GFR was above 30. It was continued till the patient has gone into a dialysis need, and nothing untoward has happened in that patient. So this drug is safe. Even if it is started in the late stage of the disease, it may have a benefit which has not yet been studied. Till 30 ml GFR, most of the trials have said that you should use it because the benefits are maximum.
Yeah, basically, no, I just wanted to tell you that the Credence data is the one where they tried they gone till eGFR of 30, and they've used, and most of the pocket inserts on the all the prescribing information do not say that 30 eGFR for SGLT2. As far as mostly in the practice, we tend to use around 45 to 60 eGFR as a safe range. Basically, we understand that SGLT2 inhibitors, the work on basing on the base of functioning nephrons. Yes. If the kidney is going to function well, and they're going to well, but so whenever the safe range, we tend to use around 45 to 60 in the practice in all our diabetic patients. And it's coming to the cardiologist, Dr. Chandrakumar Das, and which SGLT2 has an edge in heart failure? Little tricky question to you.
Yes, sir. In SGLT2 inhibitors, yeah, it's critical because if you see dapagliflozin and empagliflozin, both have shown benefit in heart failure. And even if you see in EMPEROR trial, if the patients are non-diabetic even, the empagliflozin has shown the benefit in heart failure mortality, means death for heart failure or heart failure readmission in hospitals. So which one to choose, it's very difficult. but both the molecules, dapagliflozin and empagliflozin, has shown benefit. And for, as I said before also, because the dapagliflozin, the cost has come down, so I think this molecule should be used over empagliflozin, from my point of view.
Probably, yeah. Probably that the heart failure concept came with following the MFAREG outcome. Basically, all the for all of your attention, basically all the cardiovascular outcome trials in diabetes were only aimed to say that whether the drugs can be safely used in a patient with an established cardiovascular disease. That is what the question for the CVOD trials following the rosiglitazone controversy. But during the MFAREG, we got the benefit from in terms of heart failure, after which only the trials came later. All the other trials have been, the heart failure has been included as an endpoint, and they studied. So probably after MFAREG, all the you get the declaratomy has given a very good answer, and again probably the DAPA heart study really said, you know, even in non-diabetic patients there was a benefit in terms of heart failure. So overall, you know, convincingly started with the EMPA, and now by and large, and DAPA, I think Dr. Nilakshi, you also will agree with me. The heart failure data started with the MFAREG only. Okay, then later the declaratomy and DAPA heart studies has given us a lot of inputs on that, and probably EMPA and DAPA both are beneficial. Probably dapagliflozin giving recent data, a lot of more data, and probably sometime we can say it's a class effect also. What is your take on this, Nilakshi?
So when we compare heart failure vis-a-vis as an effect of SGLT2 inhibitors, CANA, DAPA, or EMPA, we see that it was the DAPA heart failure study which actually proved beyond doubt that this is a molecule which has an effect on addressing heart failure or reducing the hospitalization for heart failure, even in those patients who did not have diabetes. So it was effective across a wide continuum of patients having diabetes or with diabetes or without diabetes. On the contrary, when we compare this data of DAPA heart failure to that of Emperor Reduce, we see that the results of DAPA heart failure were actually more encouraging compared to Emperor Reduce with empagliflozin in heart failure patients. So there a meta-analysis which compared all the three trials, EMPA-REG outcome, the Credence Canvas, and the declaratomy trial, actually came to a conclusion with the meta-analysis, that reduction in hospitalization for heart failure or reduction in heart failure is actually seen uniformly with all classes of SGLT2 inhibitors, be it EMPA, be it DAPA, be it CANA. But reduction in all-cause mortality, reduction in cardiovascular death to a statistically significant extent was seen only with empagliflozin in the EMPA-REG outcome, rather than dapagliflozin in the declaratomy, or rather than canagliflozin in Credence or Canvas. So heart failure wise, I think we have more data with dapagliflozin. But again, empagliflozin also has its own data in the form of EMPA-REG outcome, in the form of Emperor Reduce trial.
So you also, Dr. Nilakshi has also agreed with me that both EMPA and DAPA has got more evidence in terms of heart failure. Okay, and Dr. Chandrakumar Das, which SGLT2 has got an edge in patients with an ASCVD?
Sorry, here I'll say this empagliflozin, because you're directly from the this is the EMPA-REG trial. It has proven about the dapagliflozin in the declaratomy trial, where they have shown dapagliflozin have shown benefit only in the heart failure patients. But on the contrary, empagliflozin has shown this primary outcome in the form of cardiovascular death, this non-fatal MI or stroke. So I think empagliflozin is here.
Canagliflozin also has got data in terms of MACE reduction. Canvas data also says that the MACE reduction is better with Canvas. Okay, so probably canagliflozin can also be included in that, and probably when you look into the in terms of AACVD alone, Nilakshi, I would like to say that probably in terms of anti-diabetic drug, I prefer that more than a GLT2, the GLP-1 receptor agonist and DPP-4 has got a more favorable action in terms of an AACVD. So whenever that's why the guidelines have said, whenever there's an AACVD predominates, try to use a GLP-1 receptor agonist DPP-4 than this one. What is your take on this, Nilakshi?
Yes, sir. That actually came from the observation of leader trial vis-a-vis empiric outcome. In the leader trial, any benefit with the molecule liraglutide was seen after a period of say 1.5 to 2 years. So that was hypothesized to be a particular kind of time where it would influence, liraglutide being a GLP-1 receptor agonist, it would influence the atherosclerotic profile and thereby perhaps lead to the cardiovascular benefits, and hence the delay from initiation of this molecule till we achieve any measurable outcome with the as regards cardiovascular benefits which liraglutide. However, with the use of empagliflozin in the empiric outcome, when there was an analysis, retrospective analysis of the data, it was seen that the benefits as regards reduction in heart failure was seen as early as 31 days. So 31 days is not a period enough where there would be modulation or where there would be any influence on the atherosclerotic cardiovascular disease of an individual. And hence it was thought, or it was argued, that perhaps the cardiovascular benefits which we accrue from SGLT2 inhibitors are more via alteration of the hemodynamics, and the cardiovascular benefits which we accrue from GLP-1 receptor agonist are more via modulation or influence on the atherosclerotic disease process in such a patient. So, sir, as you rightly had summed up, which I kind of stretched, we zeroed down to the point that GLP-1 agonists, they are for atherosclerotic cardiovascular disease, and SGLT2 inhibitors more for heart failure.
Heart failure and CKD probably.
Yes,
Heart failure and renal protection. And to Dr. Ratan Jha, which SGLT2 you would prefer in patients with CKD again?
Based on the recent trial data, patients who are having diabetic CKD or even a non-diabetic CKD with proteinuria, if there are no contraindications, the first drug of choice is dapagliflozin, if cost is also a consideration. But in absence of cost consideration, one can even use, based on the Credence trial, the canagliflozin to get the benefit. Even the EMPEROR trial as well as the EMPEROR reduced trial, the secondary endpoints showed a similar benefit. So it is very difficult to choose. So if I have to choose one over the other, if cost is a consideration, dapagliflozin. If heart is a consideration with a history of AMA and other things, probably empagliflozin. And if nothing of that sort, people, and obesity is a problem, probably I will try to use canagliflozin, as you have spoken, that probably that reduces the body weight, and we use a high dose, 300 milligram of canagliflozin to get that benefit in addition to other benefit that is there. So that is how I choose the drug: cost, DAPA, weight, cana, heart, EMPA. But any of the things can be chosen based on your personal preference. There's nothing to say. All the three drugs have been found to have an equal kidney benefit. So far, CKD endpoints were concerned in all the trials, either primary endpoint or secondary endpoint.
Yeah, thank you, Dr. Ratan Jha. And then the question is to all the panelists. We can answer one by one. What is your take on the dapagliflozin 5 milligram in use? Is the right dose for our patients? We'll start with Dr. Nilakshi.
I always use 10 in most cases. Maybe in 99% of the cases, I use DAPA 10. And only 1% of the cases who have had say a prior episode of urinary tract infection and is an elderly individual where we already have hypotension and the individual is frail, but yet we want the benefits of dapagliflozin. In such a patient, perhaps using dapagliflozin 5 molecule to start with would be a correct way.
Dr. Chandrakumar?
Sir, I have never used 5 milligram. If all the trials and all are giving benefit with the means like a dose of 10 milligram, then why should I give 5 milligram? So in my practice, I don't use 5 milligram. I use 10 milligrams.
Dr. Ratan?
So based on the trial results, only 10 milligram is chosen. Those cardiologists are very, very skeptical of starting the 10 milligram dose. Many times they start it with low dose because the low ejection fraction is low BP. But in chronic kidney disease, BP is never a problem of low BP. It is always a high blood pressure. So I have never used 5 milligram in any of my patients.
Most of the efficacy data with the SGLT2s are done. Mostly can start with the canagliflozin or a DAPA, EMPHA. Any drug if we can take, starting with that your remogliflozin also. We have the Indian drug which undergone a research. Probably we are not discussing about the remogliflozin here, but remogliflozin is also one drug which I was personally involved in conducting the phase 3 clinical trial for the remogliflozin. Now also I'm doing a combination of the Remo-Teni and Remo-Vilda combination trials. I have a research department. I'm doing a lot of almost all the newer drugs and diabetes I work with. And mostly we have seen all the CVOD trials. They're done with the 2 dosages, starting with the Cana 100, 300, DAPA 5, 10. Most of them, the efficacy wise, everything by and large, both the strength have been found to be useful. And so I don't think there is any specific reason we should not use 5 milligram. And so 5 milligram is also as efficacious as 10 milligram, not too much of difference on data. So the next question is also coming. How often do you use DAPA 10 milligram plus Metformin 500 or DAPA plus 10 mg plus 1000 milligram? Do you think it can be used as a first-line therapy? Again, this question has been answered by Nilakshi already. Probably they've given with the combination. Probably India is known for combinations, bringing up a lot of combination therapies. And today, the combination therapy is the order of the day. So what is your take on the Nilakshi?
So it depends upon the patient's baseline HbA1c. So a patient who has a baseline HbA1c of which is around 2% above the target. Say a patient has an HbA1c of 9% and our target is that of 7%. Then with addition of a single molecule, that is metformin alone, may not suffice to bring down the HbA1c target to the desired level. So because any molecule, oral hypoglycemic agent, except sulfonylurea in the initial days, has the potential to bring down the HbA1c reduction by a maximum of 1%. So a person who is 2% above the desired target, we need to start with a combination therapy in such a patient, because the previous conventional approach of treating diabetic individuals by adding a monotherapy, then waiting for the HbA1c to go above range, and then add a second therapy, and then again waiting till the HbA1c again shoots up, it actually leads to a cumulative bad metabolic memory, because the patient spends a lot of time in bad glycemic control and spends some episodes of time having good glycemic control. So such a conventional approach of adding monotherapy and then a dual therapy, this systematic approach has now been dissuaded from use, and this especially is also backed by the scientific evidence which came from the Verify trial, which was done with vildagliptin and metformin, which showed that if we start with a combination therapy early in the course of diabetes, then perhaps the durability of each individual molecule when used alone would actually be lesser than that of the combination therapy. So the combination therapy would prove to be efficacious for a longer duration of time if used as a combination right from the day of initiation of therapy, rather than when we compare the duration of efficacy with each individual molecule being used separately. So, so that is the...
Yeah, I agree with Nilakshi. And probably, that this is what that ADA guidelines have also recommended, that when your target is 1.5 to 2% above the ratio target, always go for a combination. Do not, no more diabetes management is going by stage by stage or wait and watch. We are more proactive. The management of diabetes has become more proactive from the beginning itself. So initial itself combination therapy when the HbA1c is high, and as he said, the initial 5 years of diabetes is very, very important. I used to talk in all meetings. They call it the golden period of diabetes. When the patient comes, he is also highly motivated. Doctor is also well motivated to treat the patient. And definitely the first 5 years, we're able to control diabetes. You are doing a lot of good. The good glycemic, you are avoiding the bad glycemic memory, and you are giving the support to the legacy effect with a good glycemic memory. And this has also been supported by the data from the UKPDS follow-up data. I think all of my colleagues also will agree with me on that. And so whenever required, we start with combination therapy, and definitely more so when the patient's BMI is little higher, because metformin 1000 milligram, the higher BMI patient is also going to get benefit. And then coming on to the cardiovascular outcome trials, this is more, which study influenced you maximum among SGLT2 studies? The DAPA heart failure, DAPA CKD, M4reg, CANVAS, and declaratomy. We'll start from the cardiologist, then move to the nephrologist, then come to endo and me.
Yeah, so if you see the cardiovascular benefit for all the patients, all the diabetic patients, then this MPREC trial, it has very good evidence for the reduction in cardiovascular death and non-fatal MI and stroke. And also it has shown the benefit in heart failure patients. And similarly, if you see this CANVAS and declaratomy trial, they have shown the benefit of SGLT2 inhibitors in the heart failure and patients, and also in the connective flows in the cardiovascular patients. So it's to say the which study to influence, all the study has provided the benefits. And even if you see the DAPA CKD trial, it has shown the benefit in the progression of CKD. In the cardiac patients, we know that there can be cardiorenal disease. So in those patients also, this molecule can benefit on those patients of this cardiorenal disease also. So to say this, which one study is not, it will not be correct. All the studies have given us the insight for this molecule.
No, the question is, which are you more convinced? Which study most influenced you?
Yes, sir.
Have an answer
The DAPA heart failure, it has shown that the use of DAPA deflows in the heart failure patients. But if you come with the MPREC trial, it is not only the heart failure, it is shown the other benefits as well. X means more than the heart failure. So it's like both the studies, to use the molecules of both the studies has to be taken. In the ABS-CD patients diabetes with cardiovascular risk, then we have to go with the MPREC trial for the benefit of empagliflozin in the cardiovascular outcomes. But if it is the DAPA heart failure, then the heart failure patients, the benefit of dapagliflozin. So it's the different trials in the different
yeah.
outcomes.
Thank you, Dr. Chandrakumar, and we'll move on to Dr. Ratan. Yeah, your opinion, please. Which study has influenced you to the maximum?
No, though the first study was the MPREG trial, which was a cardiac CVOT trial, the clue came that it has an influence on the renal outcome. And subsequent to that, even the CANVAS and CANVAS-R trial was designed and gave the same information. And then they developed a credence kind of trial, data, which gave a first time information that this is truly a kind of renoprotective drug, but that was a kidney-based outcome trial, the primary endpoints, and then the DAPA CKD came. So the two trials which are kidney-specific are the credence trial and the DAPA CKD trial, which is giving the similar information to the non-directed kind of information coming from the cardiac CVOT trial, that is of MPREG and even reduced trial, which has given the same information. So all trials are giving a kind of information that this drug as a class is a highly efficacious drug so far kidney endpoints are concerned, in reducing the slope of GFR decline and reducing the proteinuria and the kind of mortality. One of the very important information which came from the credence trial, that when you are using on the top of ARB, the standard dose of canagliflozin, the decline of GFR fell down from 5 ml, which was with ARB alone, to 2 ml per minute per year. So that was a big kind of kidney protection, which means that almost 10 to 15 years can be gained if this drug can be given in the right dose in the right patient for preventing the kidney disease. And hence, we should use this drug, and we use it for that point even in non-CKD patients these days.
Thank you, Dr. Jav. As a nephrologist, you are convinced. And Dr. Nilakshi, your take on that?
Very difficult to comment as to which am influenced more, because all of these studies have been so well conducted with such a huge patient base, with such different patient baseline criteria in each of these trials, that each trial has its own beauty and it has its own results which we need to imbibe and like replicate in our clinical practice. I think I would, I cannot be biased to a particular scientific trial. Rather, I have been truly influenced by each of the trials, be it DEPA-CKD, be it DEPA heart failure, because each have empowered us to treat humanity in a better way. They have come up with, for the first time in the history of diabetes treatment with oral hypoglycemic agents, molecules which were actually evaluated to find out the cardiovascular safety or neutrality, have actually gone beyond that territory, gone beyond that limit to prove their benefits in retarding cardiovascular diseases, in retarding diabetic nephropathy. So I cannot be unjust, or I cannot be biased to any particular trials.
So as Nilakshi said, we got a very good information from all the trials, and each trials involved a different group of population. For example, if you take, M4X, the population involved was different. And as we move on to the canvas and then declared TIMI, you can see the number of people with the M4X had more people had the already had complications. So secondary prevention was trying to look into. Then later, the canvas is trying to look into people a lot of with the some percentage were around 30, I think 65-35, were with the secondary and primary prevention, and they again looked at me more towards that primary prevention when it's come. So all the, as he said, all the trials were very convincing, and so we should use it as judicially, and we should apply in our practice. I am personally I was convinced with that canvas trial because I was part of the canvas clinical trial as an investigator. I worked with, I was very happy to share with you that I worked with the canvas clinical trial, which was very interesting data. And moving on to the next one, and what are the things a patient needs to be told while prescribing SGLT2 drugs? And probably the maximum SGLT2 is prescribed by, I'm not sure, but mostly I feel probably the diabetes and endocrine people, we prescribe more SGLT2, probably next coming to the nephrology, then cardiology. So I would ask again Nilakshi to come on this, and we will go to the other panelist opinion on this. What are the patients need to be told on while prescribing SGLT2? Unmute, please. Nilakshi, unmute.
So it is actually like ABC, where we need to keep in mind that the patient's so these class of molecules would not cause hypoglycemia. So we need not tell the patient, like any other molecule in diabetes, that when you are using this molecule, you have to be cautious of these symptoms of hypoglycemia. So SGLT2 inhibitors empowers us to treat hyperglycemia in individuals without causing hypoglycemia. And with the DEPA-CKD trial, we also came to see that even in patients who did not have diabetes, still in them, dapagliflozin was effective in decreasing heart failure. So what happens is that, so we will not go into the detail why this molecule does not cause hypoglycemia. But the other thing which we need to tell the patient is that the patient may have symptoms of hypotension. If the patient already has a normal, or say we have many patients who have a low normal kind of a blood pressure. In them, when we are initiating dapagliflozin, then we need to tell the patient that they need to take a lot of water and they also have to, in elderly patients having hypotension, we have to be careful about falls, which these elderly patients may have, and thereby lead to head injury or some other kind of complications. So we need to tell the patients that if they have any such symptoms of postural giddiness or having giddiness while they are sitting up from while they are standing from a sitting position or from lying position, the patient needs a little bit of information on this. Secondly, we need to keep them informed that this molecule may cause UTI or GTI. And if any such symptoms occur of GTI, then we can also write an antifungal ointment somewhere close by, that if you have these symptoms of itching in the genital area, of white discharge, then you can apply this and see if it resolves by itself. You also have a possibility that you may develop urinary tract infection or dysuria. In that case, you have to stop the molecule and reach with the primary care physician. So these are the two things where, and also if the patient has sepsis of a major degree, in that case also the patient needs to stop. So it is, these are the kind of things we need to tell.
Okay, Nilakshi. Dr. Atanja, what will you tell your patients?
So whenever I start this drug, I tell the patient that you should take care of a genital hygiene, because you have to keep the area dry, because that is the first thing that they have to take care. Because, and if they take care, this so-called fungal infection, etc., I have never seen except in few patients in my practice, that mostly in females. So that is a very uncommon kind of thing. UTI is a possibility, and we tell them, but that is not a big possibility, because once you put a doubt of UTI, people will not take the drug. So we try to look at the background to give that information. And the third thing is that you discontinue the drug if you become sick in the form of either diarrhea, vomiting, dehydration, or anything acute you develop, you discontinue the drug and come to the medical attention.
Dr. Chandra Kumar,
Yes, sir.
what advice you will give?
Yes, sir. I used to ask them to clean the genital area. Usually, it is seen that people, mainly from not the urban, but if you see the rural areas, most of them usually they don't even have bathrooms. So it's very difficult for them to clean the genital area. So I asked them specifically that you clean the genital area, and simple itching and all, nothing to worry. And if there is, like what I said, the fever, then burning micturition and all, then definitely you should stop and come to the doctor nearby. And one thing I'll like to say, that the hypotension, what we encountered with Arnie, is very less with the dapagliflozin. I've seen very less hypertension with this molecule. It's very good in that way.
Okay. Thank you, Dr. Chandra Kumar. Probably I just want to supplement to the panelists that one, the good genital hygiene is very, very important. All the three of emphasis, and good genital hygiene, and look for any genital myocardic infections, and report or can treat it by the ointment. Number two, I explained the patient that this drug excretes the glucose through the urine. That's very, very important thing I do. So this is the new molecule which has come. It's normally people get urine, the sugar in the urine, they get scared. But we'll tell them, sometimes people check, many times in the village set up all things, patients take only the urine sugars are being checked. So when start treating, the urine glucose level increases. So we explain to the patient, this molecule excretes glucose from the blood, glucose it excretes through the urine. So there is chances of the genital myocardic infection, and good genital hygiene and report. Number two, elderly patient is, and again, the frequency of urination sometimes may be altered. Sometimes some people might complain of nocturnal, nocturia, and sometimes some people complain of polyuria, and sometimes we causing more quantities of urea at a time. It's called polyuria. So these things also you can tell, you are likely to experience little more frequency or little more excess quantities of urine. You should not be scared about it. And if you feel very dry, thirsty, you take little more water. And especially in elderly people, you have to tell them clearly that, especially when they're already on diuretic, we have to be very careful and tell them they take enough. Hydration is a key, and especially in a tropical country like India, and elderly people, we should tell them, especially in the summertime, when they should take little more water to avoid the dehydration to this. So these are the things and the patient is a little more educated, and I tell them the cardiovascular and renal. Sometimes the people come and ask you why this drug is very costly, why this drug. So we explain trying to tell them that this molecule has undergone a cardiovascular trial and is shown a benefit in terms of cardiovascular outcomes, and the renal, the heart failure again on the in terms of renal benefit. This is the third point. The patient is more, because people are more Google doctors today. They learn about this and they come with all questions. And sir, why this molecule is costly? We'll tell them this molecule has got so much proven benefits. And how do you see the usage of SGLT2 drugs in the management of diabetes and cardiovascular disease in the next 5 years? We'll start with Dr. Chandra Kumar. Diabetes and cardiovascular disease usage, SGLT2, diabetes and CV disease in the next 5 years. How do you see the usage?
Yes, sir. I think very soon the use of SGLT2 inhibitor for the heart failure will emerge as the first line therapy. Along with this inhibitors and ARBs, very soon will come as a first line in the 5 years for the heart failure patients. With all the data, they have shown that it's even as I said, then in non-diabetic patient also it has shown tremendous benefit, and in mainly in the heart failure patients, and also in embryonic reduced trial. There are around 30% patients which are non-diabetic. So I think this will come very soon with the promising, means in 5 years it will come as a first line therapy.
So I think, you as a card, we'll take your answer as a key in that, and we'll move on to the next question. And because we have got some questions in the chat box also. And I'm coming to the last part of the organized question. What is your experience of treating post-COVID-19 recovery patients with diabetes, and what is your advice to the clinicians? We'll start with Nilakshi.
So advice to the clinicians with respect to SGLT2 inhibitors.
Yeah, what is your experience treating post-COVID generally? Probably, we can have as a relevance to SGLT2 also. You can add what sort of post-COVID.
Post-COVID, once the patient has recovered and is clinically stable, has come back home and is carrying out his day-to-day normal activities, in that case, the patient can continue with the medications for diabetes. If we speak from a diabetes perspective, he can continue with the medications he was taking prior to the episode of COVID, which could include a DPP-4 inhibitor, which could include sulfonylurea, which could include SGLT2 inhibitors. And if the patient was on insulin, it could be insulin also. So after recovery, to address post-COVID, if some patients have a very long haul syndrome where they develop post-COVID complications in the form of like different complications, autoimmune complications, like the one which we have recently is the MISA, or minimum in, just forgot.
Multi-system inflammatory disease.
Multi-system inflammatory disease in adults. So in such a case, which can occur, say 6 weeks or 8 weeks after COVID infection, in such cases, we have to be a bit cautious. Otherwise, for patient who has completely recovered, I don't think there needs to be any change in the treatment for diabetes in the post-COVID period.
Yeah, I would like to add on to that. We find a lot of people treated with steroids coming with very high blood sugars, and people with many a time, a lot of new onset diabetes are coming, and diabetes becomes uncontrolled because most of the COVID-19, we've seen already patients on whether insulin or tablets, the blood sugar level has gone up, and anytime COVID resolves, but their blood sugars goes high. Many times people land up with diabetic ketoacidosis, and many a time a lot of fungal infection. Personally, last 1 month, I've treated 3 cases of fungal infection. One in rhinocerebral mucormycosis, another one on sphenoidal sinusitis with aspergillus, other one COVID with lung fungus. So 3 different cases of fungal infection with high blood sugars I have treated. So very, very important is keep monitor the blood sugar very closely, because most of them are treated, because a lot of more than 50% of the people in COVID are treated not only by the private setup, they are treated by the government setups also, where close monitoring of blood sugar is practically very, very difficult to monitor the blood sugar and give insulin in the government setup, because one staff nurse or a doctor sees 100 patients. Definitely most of our healthcare workers are tired and burnt out. So such situation, they're able to control the COVID recoveries and patient finally lands up with a mucormycosis. And on mucormycosis, we have operated in our hospital, and the patient got better. So I just wanted to tell you the blood sugars control is very, very important. And many a time we get COVID unmasked diabetic, pre-existing diabetes, and the insulin resistance increases. And so last week I saw 2 patients who were not known diabetic admitted for COVID, and then checked the blood sugar was HbA1c was 11 and 12, husband and wife, 11 and 12 HbA1c percentage. So really surprised. And in this patient, they were not totally asymptomatic and running around. And so always look for blood sugars and blood sugar control. Preferably, I prefer most patients with COVID, the insulins, and follow the blood sugars very carefully, at least for a period of a month, because most of the time the steroid usage, many a time, the steroids are being used following the guideline, and we can't blame on all our colleagues. And sometimes the steroids are being used rampantly, and a very high dose of steroids for longer time. And so when steroids are being used, always be very careful to control the sugar. And many time we're getting a lot of the mucormycosis and aspergillus, which is a really troublesome in patients with diabetes. This is my take on it. I think our colleagues Ratanja and Chandra Kumar, your take on this, so that we'll move on to the panel questions.
The point that you highlighted, that in any acute situation or any severe hyperglycemia, SGLT2 inhibitor is not the drug to be prescribed. Like you said, that long COVID, that post-COVID complication, we have to use insulin. Probably that is not the time to use this drug for glycemic benefit. We have so many years to get the benefit of SGLT2 inhibitor once the patient gets adequately controlled for diabetes. So for acute situation, neither in kidney practice nor probably in the non-renal practice, probably we can advocate SGLT2 inhibitor to be used. And if sugar is not controlled, the mucormycosis and fungal infections are quite common, that we have also seen, and which is devastating. So SGLT2 inhibitor is not to be used post-COVID unless the diabetic control is ensured, that is there for 1 to 2 months, that as you said.
Dr. Chandra Kumar.
Yeah, sir. For post-COVID patients, like for the known cardiac disease patients, I would advise to the physicians to continue the cardiac medications. Because, and one thing is that in post-COVID, it's seen that there is most of the time there is tachycardia in the patients of post-COVID. So whether they're if they're a non-cardiac patient, then it's okay, the tachycardia may not harm. But if the patients are having some cardiac disease, so tachycardia is not encouraged in the cardiac patients. So the management of tachycardia, whether if it's the beta blocker or other the drugs that can reduce the heart rate, should be added in those patients. So I think from my side, from the cardiac side, that is that what I want to tell the clinicians.
So we will, I think we'll go on to the questions in the chat box, and because we are already running time. I think Dr. Devak Sharma has commented that in my practice, I have seen the weight loss with SGLT2 is quickly regained once the drugs are discontinued. Please share your experience. What is the utility and limitations of SGLT2 drugs in renal diseases? Probably we will start with the first question to Dr. Nilakshi. They regain the practice once the drugs are discontinued. What is your experience?
So what is
Unmute,
the question?
The Dr. Devak Sharma has said that in the practice, once the SGLT2 discontinued, the patient regained weight. What is your experience?
Yes, so they will regain the weight. That is true. The patients will regain because this is causing loss of calories. It is causing glucosuria. So thereby it is acting in a way to address the weight loss. But once that effect is not there, then the possibility is that the patient may regain the weight. But if the patient continues to take this, then he will continue maintaining the particular weight he has achieved. So it would again depend upon the lifestyle of the individual, which will actually rather influence the patient's weight gain potential. This molecule can only aid in bringing about reduction in weight, but that has to be maintained by the patient's own effort of maintaining a proper diet and exercise regimen.
Yeah, very important is to follow up the lifestyle modification. If you're able to follow the lifestyle modification, definitely the weight loss can be, the lost weight can be maintained. Once the patients, the blood sugar comes down, many times they go again, the complaints with the diet become poor and they continue to eat and they do not do exercise. So the lifestyle modification we're able to do to reasonable extent, you can continue to maintain the weight loss, which you already gained with the SGLT2. And probably this question is to the Dr. Ratan Jha. What is the utility and limitations of SGLT2 drugs in renal diseases? Any difference within the class as far as renal aspects are concerned?
In my 3 years of focused practice on using SGLT2 inhibitor in diabetic kidney disease, what I have seen is that all the three classes of drugs are having a benefit so far proteinuria is concerned. The eGFR slope has come down, but not to the extent what is reported in the literature because of maybe the non-compliance with other kind of medicine that is there. But none of the patients had to discontinue the drug for a UTI in a patient where I have used it because we have selected the patient that way. When the GFR has gone below 30 ml, as per the earlier indication, we have discontinued the drug. But as per the Credence trial, it was found that this drug can be used even in later stage without any kind of mishap because the drug usage that is there. So the concept that this drug is being practiced in nephrology for glycemic control is not there. We are using this drug only for the renal benefit and cardiac benefit. Because the glycemic benefit when the GFR comes down below 45 ml is very little. It's not a big kind of benefit that is there. So we are using it for the non-glycemic benefits. That is a pleiotropic benefits of this molecule. Now, all the three drugs are found to be efficacious.
Yeah, okay. Thank you, Dr. Ratan Jha, and probably Dr. Surinder Gupta from Ludhiana, Punjab has asked, SGLT2 inhibitor, which is better, morning or evening dose? And also he has asked how they affect the GTT. Can diabetic on SGLT2 inhibitors have a relatively normal GTT? Dr. Nilakshi?
Yes, sir.
Yeah. Did you listen to the question? Yeah, SGLT2 inhibitor, which is better, morning or evening dose? Or how they affect the GTT? Can a diabetic on SGLT2 inhibitors have a relatively normal GTT?
So morning dose is better for, especially dapagliflozin also advocates for a morning dose of say SGLT2 inhibitor. Even Canvas, the canagliflozin also they advocate for a morning dose, but it can be given at night also. There's no particular time that we can give because these molecules do not have a hypoglycemic potential. So there's no really question of whether that would not influence our decision of whether the molecule has to be given in the morning or at night. But one thing is that when we are introducing an SGLT2 inhibitor in any patient, it may at times lead to increased urine output for the initial 2 to 3 weeks. So during that time, say the patient has to travel for a long distance, 1.5 hours to his place of work, and if it takes the molecule in the morning, then it is likely that the patient would need to use a washroom in between during the transport time. So we can ask the patient in such a case if he develops, because this is not a uniform complaint by all patients, or this is not a uniform response in all patients, but in those class of patients who do complain of increased urine output in the morning half after taking SGLT2 inhibitors, and they have difficulty accessing the bathroom or washroom to empty themselves, in that case, maybe giving this SGLT2 inhibitor before their dinner or at night would help the patient accommodate or adjust to their lifestyle.
Probably I will try to answer the second part of the question. Probably GTT and an SGLT2 inhibitors. Probably, when you diagnose the diabetes and basically there is no need for a person to do a GTT for already established diabetic patients, unless in case of some research it is done. And nowadays the GTT is being no longer not much practiced also for diagnosis of diabetes. We use more by HbA1c and blood sugar levels itself. So GTT is not a concern when you are using an SGLT2, and it's not indicated at all. And Dr. Ravana Siddhappa is asked about when to add an SGLT2 inhibitor, probably, with the when to add an SGLT2 inhibitor in a DKA patient. So this question probably, Lakshi, when to add an SGLT2 in a DKA patient?
Never, never, sir. That is the only contraindication for its use. Patients having type 1 diabetes or type 2 diabetic individuals who are in a catabolic state, who are lean, thin, and insulinopenic, they are the potential contraindications for use of SGLT2 inhibitors. Also in setup where the patient is going through a stage of acute infection or acute sepsis, has had a major has had a major surgical intervention from which the patient is recuperating. These are the instances where SGLT2 inhibitors need to be used, need to be withheld. They have to be stopped for that period. And if a patient develops ketoacidosis with this, then perhaps we are not treating type 2 diabetes. It could perhaps be adult onset type 1 diabetes if we find. So that also needs to be kept in mind, that all type 2 diabetes individuals, that all adults having diabetes are not actually type 2 diabetes. Even adults can develop type 1 diabetes for the first time. And these are the class of patients where we need to keep our suspicion or the scrutiny really on and be cautious in using this class of molecule in such patients.
Yeah, initially the SGLT2 came itself, there was some case reports of euglycemic ketosis. Okay, so majorly it was hyped at the time. Then later they found that euglycemic ketosis was found in type 1 diabetic patients and the patients with high insulinopenia and patients with brittle diabetes. So as Dr. Nilakshi said, and probably DKA is not the place where you can use this at all, and probably you should keep a watch on that, especially in the patient had recurrent episodes of DKA. You do not use that. And Dr. Pranesh has asked one question that what happens in a patient when they use an SGLT2 in lean diabetic patients? Obviously, most of our Indians, we find that we are thin fat Indians. Our body mass index might be might not be very high, but your visceral adiposity might be high, and by and large we found that whenever the baseline BMI is high, the weight reduction in the glycemic benefit is also better, but it also works in a patient with a normal BMI, and but not in a very lean individual. Probably, if you can say, where they are insulin in type 2 diabetes, when you find very lean individuals, sometimes we find they are insulinopenic, and such individuals probably they are not the case. Otherwise, with a normal BMI patients with a visceral obesity, definitely these drugs can be used. And like other OHA failures, can we get SGLT2 failure, whether it happens? And I don't think there's data to suggest that so far the SGLT2 failure, because SGLT2 works on a totally different mechanism. As I already said, that kidney is a major, as long as your kidney function is fine, the SGLT2 are going to work. I think my nephrology friend, Dr. Ratan also will agree with me that as long as the nephrons are going to function, the SGLT2 is going to function. Am I right with you?
Yes, sir.
As long as there are some functioning nephron, it is going to work, and there is no question of failure. And as Nilakshi initially said, it can be used in the wide variety of diabetic patients, wide variety of situations, starting from the newly diagnosed diabetes to the later stage of diabetes. So there is nothing like SGLT2 failure so far has been documented as such. And please tell about Remo efficacy in heart failure and compared to DAPA. So remogliflozin is under the study. Probably remogliflozin, we need to wait for some more time to get more data on remogliflozin on heart failure data. People, when we all, at this time, we all feel that it is a class effect. Nilakshi, do you agree with me that probably as the SGLT2 have got a class effect in terms of efficacy in heart failure? Probably when something good, people want to say as a class effect. So as I feel that probably remogliflozin also has got a class effect. In terms of heart failure, probably we need to wait for more data to come on remogliflozin. Okay.
In fact, the phase 3 trial with remogliflozin was in comparison to dapagliflozin. So I think that would also be a class effect, sir, as you rightly said.
Yeah, and again, the last question, probably patient age 60 EGFR 54 microalbumin 223 and glimepiride 3. In this condition, is it good to decrease glimepiride to add when you add SGLT2? Obviously, when you add SGLT2, as already Nilakshi said, that it cannot cause hypoglycemia, but it can cause hypoglycemia when it's combined with insulin and sulfonylureas. So whenever you add on to sulfonylureas, be cautious. Always look for a hypoglycemia. So whenever you can reduce the dosage of the sulfonylureas and insulin, when you add SGLT2, and closely monitor, and do not try to abruptly withdraw insulin, especially in the patient. Sometimes they can push in the patient for ketosis. So glimepiride dosage can be reduced when you start on SGLT2. And the last question, can we start DAPA met for newly diagnosed question? I think this question has been already answered by all the panelists. DAPA met can be started for all newly diagnosed diabetes. I think we have had a wonderful round of panel discussion with all my co-panelists, Dr. Nilakshi Dekha and Dr. Chandrakumar Das and Dr. Ratanja. And they've taken the panel discussion very lively and wonderful, and they've answered to the points and very brief. Thank you on behalf of the scientific team. I thank my panel endocrinologists and the cardiology and nephrology colleagues for being with me and taking this discussion to a wonderful level.